All right, so now we're going to talk about metabolism. We'll start with hypothalamic and pituitary agents. A few hormones we need to talk about as far as the anterior lobe goes. Follicle stimulating hormone. This one affects ovaries and testes primarily, is what we're doing there. Adrenocorticotropic hormone. With that one, we're looking at the adrenal gland and the release of glucocorticoids and mineralocorticoids, and we'll get into those. Those are going to be important, not necessarily with this chapter, but in the next couple chapters. Thyroid stimulating hormone does exactly what it says. It stimulates the thyroid. Prolactin. There we're primarily concerned with the growth of breast tissue and milk production. And then, of course, growth hormone stimulates growth in the tissues and bone. As far as the posterior pituitary hormones, the antidiuretic hormone, this one's important. We will talk about this one with this chapter. It's the one that promotes water reabsorption and maintains water balance. And then oxytocin, it's uterine contractions and milk release. It does play a role in male sexual performance, but we're not really talking about that until the end of the semester with reproduction. So let's get started with growth hormone agonist, somatropin. So like we talked about with growth hormone, stimulates the growth of tissues and bone. And the action of this is just replacement. This is one of those that simply replaces hormone that or insufficient amounts of hormone that our body has. That's the most common indication is growth hormone deficiencies, those people with growth hormone deficiencies. There are other actions, there are other indications for this. It can help with people that are having difficulty with wasting, such as people in AIDS. It will help them with protein production. There's others as well, but what we're mostly concerned about is the growth hormone deficiency. Adverse effects. There's quite a few. One that we definitely want to make sure we're aware of is hyperglycemia. Anybody that's on this medication is going to need to be monitored for the signs and symptoms of hyperglycemia. Contraindications. So we're taking it to promote growth in those with growth hormone deficiencies. So we need to stop this when they're fully grown. And that would be indicated by closed epiphyses. When those growth plates have fused and the bones have stopped growing, we don't want to continue this because this will continue to cause tissue to keep growing. And we don't want to do that. So once they have fully grown, the person would want to stop taking it. Be careful then, of course, in people with diabetes because of the hyperglycemia. Interactions, glucocorticoids, which we'll talk about here in a little bit, those also stimulate can potentially cause some hyperglycemia. So there's a potential there for interactions. Patient teaching. Well, we'll definitely want to teach them how to take this. There's different ways of doing it. It's injection, but there's different injections. It could be sub-Q. Sometimes it's just a fine mist that's injected through the skin. There's different little injectors for that, but what we're going to talk about is just how to administer it. We're going to want to educate the patient and family, because it's usually kids that take this, on the symptoms of hyperglycemia and what to watch out for. The primary symptoms of that, of course, being polydipsia, polyuria, polyphagia. we'll tell them to kind of watch for that, and if they notice it, they need to get a hold of their doc and have their blood glucose tested. And then, of course, they'll also need to know about follow-up appointments to have their growth monitored. We're going to have to monitor their growth, see how they're doing, and make sure it's working, they're getting the right dose, not getting too much, and then also when to stop. The other hormone we're going to talk about for this chapter is the antidiuretic hormone. Desmopressin is the medicine for that. And its action, again, is just to replace antidiuretic hormone. There are other reasons we use this outside of just replacement, but what we're primarily concerned about is diabetes insipidus. That's our primary indication. Diabetes insipidus, of course, is a lack of ADH. It's a lot of times secondary to damage to the pituitary gland from whether it's head trauma or surgery or a tumor. It can be acute or it can be chronic. And these guys are, they're just urinating constantly. Normally, a normal person urinates about 3 quarts a day. Whereas these guys can urinate up to 16 quarts or 15 liters a day. It's pretty dramatic how much they urinate. So we use ADH to help promote that water reabsorption. Adverse effects. So if we're holding on to water, if that's what the medicine is doing, it can cause overhydration. Or water intoxication. This would be marked by drowsiness, lightheadedness, a headache. It can get so bad that one goes into a coma or starts having seizures. So we'll want to watch for that. We'll want to watch for vertigo, headache, of course, those types of things. We don't want those to continue to develop into serious problems like coma and convulsions. Contraindications, coronary artery disease, because there's an effect there on that system with this medicine. Be careful then, of course, with people with electrolyte imbalances, because we're going to potentially cause more problems with that by having them hold on to more water. Interacts with tricyclic antidepressants and alcohol. And patient teaching. So patient teaching, this one is administered frequently, most commonly through a nasal spray. So we're going to teach them about how to take that, how to get the medicine. We're going to teach them about, hey, look, your urine production should decrease. So keep an eye on your I's and O's, or mostly your O's. Just make sure, let's see that it's working appropriately, that your urine production is decreasing. They'll need to know to follow up with their provider to kind of watch that. They're going to need to follow up with their provider also to watch lab work. We're going to watch metabolic panel, UA, specifically specific gravity and dilution. And then we'll want to teach them about the signs and symptoms, those early signs and symptoms of overhydration, headache, lethargy. They'll need to know those as well and watch out for that. Adrenocortical agents. So now we're going to talk about those glucocorticoids and mineralocorticoids that we were talking about in that previous chapter. The adrenal glands. So here's a little slide for you to kind of interact with. So draw a picture of where they're located, and that's right on top of the kidneys. They're the hat there on top of the kidneys. And then look at a cross section of an adrenal gland. You have the cortex, the outer part there, and then the medulla, which is the inner part, and they each make specific hormones. The medullary hormones That's your norepinephrine and epinephrine. So it's neurotransmitters that are made there in the medulla. Whereas the cortex makes corticosteroids, glucocorticoids, and mineralocorticoids. And that's what we're concerned about with this chapter. So again, the adrenal medulla, that's your neurotransmitters, norepinephrine and epinephrine. The cortex, that's your corticosteroids, mineralocorticoids, and glucocorticoids. Androgens we will talk about in the last lecture. That is a reproductive. It's primarily reproductive medication, or at least that's what we're going to talk about these androgens for. The glucocorticoids, these are used to stimulate an increase in glucose levels for energy. Mineralocorticoids, they primarily affect electrolyte levels and homeostasis of those electrolyte levels. So let's talk about those a little bit. Glucocorticoids, there's different types as far as medications. Prednisone, this is a PO-only medication. Many of you have probably been on prednisone at one point or another. It's we use it for inflammatory processes, allergic reactions. A lot of people that I've talked to that have been on it, or they've been on it for like poison ivy or something along those lines. Methylprednisone, this is administered lots of different ways. PO, IV, intra-articular, so they can actually inject it straight into like the joint or the knee, usually the knee. Hydrocortisone, we can do that almost any way. I mean, it's PO, it's IV, it's IM, it's topical, rectal even, intra-articular, ophthalmic, just about any way you can think of. Hydrocortisone is taken. It's very common. A lot of us may have used it at some point in time if we had like a rash or something. Again, like poison ivy, sometimes hydrocortisone will help with that. If not, we may need to go to a PO or a systemic with the prednisone. These are all very common medicines. So the action, what do these do? These actually do quite a bit of things. The primary action is to mimic the natural hormone, right? So our natural glucocorticoids, and those have anti-inflammatory but also immunosuppressive effects. And so that's the reasons why we're going to take these. These other things that these do, other actions, they increase glucose level for energy. They actually increase the rate of protein breakdown and decrease protein formation. So if we're decreasing protein formation and increasing the rate of protein breakdown, that's going to affect wound healing. And then these can also help with the storage of fat. So those are some of the actions of glucocorticoids. And then the indications are based there on those actions. So adrenal insufficiency, if your body's just not producing enough glucocorticoids on its own, you can take some, you can take medications for that, like prednisone, methylprednisone, whatever. One of the more common reasons that we see these used is treatment of allergic reactions and inflammatory disorders. But you'll also sometimes see them used for immunosuppressive reasons as well. So there's many different indications for these medicines. Adverse effects, hyperglycemia is one. If they're systemic, you're going to get those systemic effects. Hyperglycemia, immunosuppression. If it's a topical or a local one, then you'll get more localized effects, such as redness, irritation to that area. They can also cause some thinning of the skin if you're using topically. But systemically, again, hyperglycemia, immunosuppression. They can also cause some edema and weight gain. People that are on long-term steroids will get kind of that moon face. They'll get, their face will get rounded. So there's quite a few adverse effects, especially with the systemic ones. Contraindications. So if we can potentially cause immunosuppression, we would not want to take these with active infections. However, you will every once in a while see that, but it's always a risk-benefit thing. It's, what's the benefits of these compared to the risk. But you certainly, any sort of major active infection, you would definitely not want to take these. They can become worse. Obviously, we're going to decrease their immune response and their inflammatory response, so the body's not going to be able to fight that active infection, especially like fungal infections, severe viral infections. But any sort of infection like that, we could potentially cause problems. So that's your contraindication. Your caution, so hyperglycemia is a potential problem. So anybody with diabetes, mellitus, we're going to be very careful with them if they have endocrine disorders. Also, peptic ulcer disorders, that kind of goes back to an adverse effect I forgot to mention. These can cause some irritation of the peptic lining, potentially causing some erosion. So anyone that has peptic ulcer disease already, we'd be very careful with. We don't want to exacerbate that. Interactions. These can interact with alcohol. They can interact with oral anticoagulants such as warfarin. NSAIDs as well. There's potential for interactions there. And then, of course, vaccines, because if you're taking an attenuated, it's a live vaccine, but obviously the virus has been weakened significantly. However, if your immune system is also weakened significantly, then you could potentially get the full effect of that disorder. So we'd be very careful with vaccines. We would want to not give those while someone is on long-term glucocorticoids. There's also quite a few other drugs, but those are the ones we'll focus on for this class. Patient teaching. So what are we going to teach these guys? Well, the big thing about patient teaching is take as prescribed. I know that we teach everybody for every med to take as prescribed, but these usually have very special instructions. I have seen some pretty elaborate instructions with these meds, such as take 2 in the morning, 3 at night for 2 days, and then take 1 in the morning, 2 at night for 2 days, and then take 1 in the morning. I mean, I've seen them even more specific than that. I've also seen them give a high dose, but for short run, like 3 or 4 or 5 days. Generally, it's a long-term, or even for something like an allergic reaction, you're still on it usually for 10 days or more. And they gradually step you down, because you can't just take these for so many days and then just stop, because it's going to throw your body into an imbalance. Like I said, there are times when they'll give you a pretty good dose for just a couple days, because the research have shown that that's potentially safe for certain problems. But generally, you need to step these down. And now there's a lot of research that shows actually just 1 time a day is probably not the best way. We need to keep your levels at we need to keep you at a certain level. In order to do that, you need to take certain amount of medications at certain times of the day. So you may see very specific instructions. So now we got to stop and think, is this person going to be able to follow these instructions? Is this something that this person's going to be able to do on their own? Do we need to get somebody in there to help them with that? Do we need to talk to the doc and see if maybe there's a little more simpler instructions for them? Those types of things. But we want to make sure, first and foremost, they understand what the medicine, what it is, and how to take it. What the specific instructions are for them. And then we want to let them know, don't stop abruptly. So yes, they're going to start feeling better fairly quickly with these medicines. But just because you're feeling better doesn't mean it's all over. So you need to take these until exactly as directed until finished. So do not stop abruptly, and we slowly bring you down off of these. We're going to let them know these are going to suppress your immune system. So, try to avoid people with active infections. Be aware of the signs and symptoms of infection, and talk to your doc. And then we talked about these can irritate the lining of the stomach, so take these with food. That's usually how these are taken. Mineral corticoids, fluticortisone. This the action here is to increase sodium reabsorption and potassium excretion, and it leads to sodium and water retention. Indications: adrenal insufficiency, so your adrenal glands just aren't producing mineral corticoids effectively. And we also sometimes use these for orthostatic hypotension, and you can see how that would work because these cause sodium retention, which also causes water retention. Water retention will cause our blood pressure to go up. There's quite a few adverse effects, and they're very similar in some ways to glucocorticoids. The edema, mood swings, and anxiety. That actually can potentially occur also with the glucocorticoids when we're on them for long term. GI upset. These can also, though, cause some hypertension, some heart failure, and hypokalemia. We talked about indications. I'm sorry, and I talked about adverse effects on the last slide. I'll go through them real quick. Edema, hypertension, heart failure, hypokalemia, anxiety, mood swings, GI upset. Maybe some insomnia in there too. Why not? Let's just throw that in there. I think it's a good idea. Just throw it in there. Contraindications, again, active infections, especially those fungal infections. Hypertension, like severe hypertension, uncontrolled hypertension would be contraindicated as well. Be careful in people with if they just have hypertension. So it would be contraindicated in severe uncontrolled hypertension, but anyone with hypertension, we'd want to be careful with them, watch them a little closer. If they have heart failure already, we'd be really careful with that. Depending on the level of heart failure, it may end up becoming contraindicated. Osteoporosis, diabetes, be very careful with people with those problems. Interactions, they can interact with diabetic medications and anti-seizure medications. So patient teaching, what are we going to tell them about this? Again, special instructions, so they're going to take them as prescribed. We're going to tell them whatever the docs decided is the best course of action for them, assess their ability to comply with that, and get them whatever help they need if needed. Again, do not stop abruptly, may suppress the immune system, and take with food. So very similar to our glucocorticoids. All right, thyroid and parathyroid. The thyroid gland. So the hormones produced by the thyroid gland are T4 and T3. The body uses iodine that's found in the body to produce those hormones. And thyroid hormone has a lot of effect on our body, especially with metabolism. That's the big thing, right? Heat production, so body temperature, oxygen consumption, even cardiac output. It affects metabolism of carbohydrates, fats, and proteins. So what is hypothyroidism? So it just means we're not making enough thyroid hormone for whatever reason. Maybe the thyroid gland itself is affected for some reason. That's usually the primary reason. Secondary reason is lack of TSH secretion, and that's from the pituitary gland. We already talked about that a little bit. So that does occur. Sometimes it could be damage to the pituitary gland for various reasons. It can cause lack of TSH secretion. If you're not putting out TSH, thyroid stimulating hormone, then your thyroid's not stimulated to make the hormone. Our symptoms. Everything kind of slows down with hypothyroidism because remember, thyroid is really affecting metabolism. So if we think about what the metabolism does for us, we can think about what hypothyroidism does to us. Causes fatigue, emotional changes, slows the pulse, weight gain. So we're not metabolizing as much. Constipation. So again, everything slows down. Also causes some memory impairment, dry skin, cold intolerance. You'll see that again. So think about hypothyroidism. Everything slows down. Treatment for hypothyroidism is a medication. They're going to need to be on medication for life, and we'll talk about that medication. There's one primary medication that we use. There's another one that we use sometimes. Levothyroxine, that's your primary medication, the T4. It replaces low or absent levels of thyroid hormone for whatever reason, whatever happened to cause the hypothyroidism. This medicine actually replaces that hormone. It's usually lifelong. It's not too common to get acute hypothyroidism. I'm not going to say it doesn't happen. I'm just going to say it's not common. Most commonly, these people are on it for life. Our action, again, replaces that thyroid hormone that increases the metabolic rate and helps get rid of those symptoms that they were having with the hypothyroidism. Adverse effect. These are actually very well tolerated as long as you've got the right level. So as long as we're at the correct dose, not too many adverse effects. The adverse effects then would be just basically symptoms of hyperthyroidism if we're getting too much. So think of it with hyperthyroidism, think of it as the exact opposite, obviously, of hypothyroidism. So instead of everything slowing down, everything speeds up. So tachycardia, instead of the temperature lowering, it can go higher. You can have a low-grade fever. Instead of weight gain, you have weight loss. So that's the most common adverse effects of levothyroxine. If they're not getting enough levothyroxine, then they'll start to have their hypothyroidism symptoms again as well. So these guys will need to be monitored throughout the course of their treatment, which is really for life usually with these guys. Contraindicated, if they have an acute MI, it would be contraindicated. If they're currently having thyroid toxiosis, so I mean, if that's one way to get hyperthyroidism. It's like an extreme hyperthyroidism. Obviously, we wouldn't want to give them this with that. Be careful though in people with hypertension and coronary artery disease and diabetes. Interactions. These can interact with antacids, can interact with iron and calcium, anti-seizure medicines, antidepressants, and warfarin. So it's got quite a few interactions. It's, again, always a risk-benefit. Let's take warfarin, for example. Levothyroxine can increase the potential effects of warfarin. So increase the bleeding risk is basically what it can do for people on warfarin. However, if you need warfarin and you need levothyroxine, you're going to end up being on both. All this means is we need to watch your INR probably a little bit closer. If you have been on warfarin this whole time and now you're going to be on levothyroxine, they may need to decrease your level or your warfarin. So they'll just watch it a little closer. Patient teaching. So patient teaching, the big thing with that, number one anyways, take on an empty stomach, usually before breakfast. Meds, as we talked about earlier with the first lecture, if you can remember back to that PowerPoint, we talked about the difference between generic and name brand drugs, and the big difference being bioavailability. This is one of those drugs that very commonly people have to be on the name brand because of the risk for effect of bioavailability. This med is given in very, very small doses, like micrograms. could be 25 micrograms, 50 micrograms, 100, 125 micrograms, but even 125 micrograms, still very, very small amount. Any difference in bioavailability, anything that can affect bioavailability, excuse me, can affect greatly the amount of medicine that gets into the system. So food can greatly affect how this gets into our system. So it's better to take it on an empty stomach to allow the pill to be absorbed and for bioavailability to be as increased as possible. So it's best to take these on an empty stomach. We also, of course, want to teach them the signs and symptoms of hyperthyroidism because they need to watch for that, like, palpitations, racing heartbeat, irritation, things like that, increased temperature. We're going to need to tell them, it's very important to make sure they understand when their follow-up visits are and to keep those follow-up visits because they're going to need periodic labs to check how well the medicine is working for them. It's very common, especially in the beginning, to need adjustments. But even as you go on, as life goes on and you take the medicine, there's going to be times when you just need a bump up a little bit. Very common to happen. So you'll need to make sure that they understand when their follow-up appointments are and to make sure they keep them because it's very important to get those levels checked. And then, of course, we're worried about bioavailability with those generic and name brand drugs. So it's best if they use the same pharmacy. We talked about this again with the first lecture. Different pharmacies can make their generic drugs differently. I mean, it's the same active ingredient, but the inactive ingredients are different, and that can affect the bioavailability. And with this medicine, that can affect the way the medicine works. It is best for them to try to stick with the same pharmacy. It's not always possible. Let's face it, the insurance has everything to do with that. I mean, I know us personally, just my family has bounced around to different pharmacies because the insurance tells us, no, we're going this pharmacy, now we're doing this one. But we can still educate them on that. And even with the same pharmacy, if they decide one day that another manufacturing pharmacy is going to give them a cheaper deal, I can guarantee they're going to go with that one. So then even if they're using the same pharmacy, they still will have the potential to have an effect on bioavailability. But it's still a good practice. We still will recommend doing that. Okay, so hyperthyroidism. So what causes hyperthyroidism? It's an excessive secretion of thyroid hormones. It can be caused by nodules, Graves' disease, thyroiditis or inflammation of the thyroid. The symptoms, again, the exact opposite of hypothyroidism. So rapid pulse, palpitations, low-grade fever, heat intolerance, very irritable, nervous. They can also get an enlarged thyroid. However, don't always go by that because you will see sometimes a goiter in someone with hypothyroidism as well can occur. But that is something that we think of a lot with hyperthyroidism. So the medicines that we use for hyperthyroidism. The propylthyracil, I think I've given this maybe a couple times in my life, and methimazole. These are the medicines that are used. The problem with these medicines is the adverse effects. They're pretty great. They're pretty significant. So they're not the best tolerated medicines, and certainly not for long term. So if the hyperthyroidism is chronic or long term, they're going to need another way to treat it. A lot of times it's just treated by destroying the thyroid, whether it's surgical or through radioactive iodine. Remember, iodine, the body uses iodine to make thyroid hormone. So any iodine that you take in, which nowadays we get iodine a lot through our salt, your body immediately just absorbs that right up with your thyroid just absorbs it right up. If we make that radioactive iodine, your thyroid's just going to suck that up. It's going to destroy the thyroid. And then the person they'll no longer have their hyperthyroidism, but they now will have hypothyroidism, and they will need to have levothyroxine for the rest of their lives. But it's, as we talked about with levothyroxine, there's really not many adverse effects associated with it as long as we're taking the right amount. Whereas these medicines have some pretty significant adverse effects, especially the longer we take them. So our indication, again, hyperthyroidism, whether it's Graves' disease or thyrotoxiosis or whatever it is, it's hyperthyroidism. That's the reason why we're taking it. So let's talk about those adverse effects. These are pretty significant. The ones that aren't too concerning are your symptoms of hypothyroidism. If you're getting too much, you're going to have those hypothyroidism effects. Again, everything slows down. So the constipation, lethargy, weight gain, all of that stuff. Bradycardia. The significant adverse effects occur with the liver. Severe liver injury can occur. Also, severe leukocytosis, so a significant decrease in white blood cell production can occur with these medicines. So we're going to have some bone marrow suppression. And especially the longer you're on these, the more significant that liver damage and bone marrow suppression becomes. So people, again, that need these for long term, a lot of times what they're going to do is just destroy the thyroid. And then you'll be on levothyroxine, far more tolerable medication. Be careful then, of course, in people. So contraindications would be anybody with liver failure. It's also contraindicated in pregnancy and lactation. And be careful with people that already have a history of liver problems. If they've already got some liver problems, if they already have some bone marrow suppression. And it's all about the level. If you already have significant bone marrow suppression, it's not going to be a good idea to take these. There's a different way that we can treat it. Same with liver failure. If you've got significant liver failure already, it's not a good idea to take these. That'd be contraindicated. We'll just treat it some other way. Interactions, again, anticoagulants, because it's going to increase the risk of bleeding. And then digoxin, it can actually, the digoxin will decrease the effectiveness of the antithyroid medication. So our patient teaching. Takes about 1 to 2 weeks for the effects to be felt. These, we take these with a meal. And usually it's like 3 times a day. So we take it with each meal. We'll teach them about whatever the doc prescribes, however they prescribe it. It's not like everybody takes them that way. It's common. Do not stop abruptly, though. And then report signs of hypothyroidism. So they'll need to have their labs followed. They'll need their thyroid labs followed, but also their liver enzymes followed, and probably their white count as well. You won't see these as often. These meds are not nearly as common as levothyroxine. Levothyroxine, I'm willing to bet you will have a patient almost every single day if you're on a normal unit. Of course, back in the day, we would have 8 patients, and now you've only usually got about 4 or 5. But I'm still willing to bet, if not every day, at least a few times a week, you are going to have a patient on levothyroxine. You're going to give it all the time. It's a very common medicine. These medicines, the antithyroid medicines, the PTU and all that, those are not very common. And then we already talked about why, because the adverse effects are pretty significant, and it's easier just to destroy the thyroid and take levothyroxine forever. It is easier. The other thyroid medicine that I didn't mention, I don't really put in here, but I'll run over it real quick in case you see it, because you're seeing it a little bit more right now, and it seems to come and go, whether people use it or not. It's called liothyronine. Again, I don't expect you to know this for the exam, but I'm going to throw this in here for ATI purposes and just for your general knowledge, because you may see this and go, what the heck is this liothyronine? I never heard of it. So now at least you can say you've heard of it. Liothyronine is your T3, whereas your levothyroxine is your T4. Liothyronine, it's got a shorter half-life than levothyroxine. They don't use it as much. Levothyroxine is the go-to medicine for hypothyroidism. Liothyronine a lot of times is taken with levothyroxine because people, maybe their thyroid levels are good. Maybe their thyroid levels fine. It looks good, but they're still having symptoms, especially some of those more emotional symptoms. They may try liothyronine with it to help stabilize that. That's primarily the way I've seen it given. There may be other ways that they give it. I've never seen it given as the primary medicine. Levothyroxine is still the primary medicine. But liothyronine sometimes is given kind of like an adjunct to that primary medicine for those that are continuing to have symptoms, though their thyroid levels look good. Everything looks good. To help with that. I've certainly seen it given like that. And the research out there, it's kind of inconclusive. There's some research out there that shows positive effects, some research out there that shows not really, or negligible, nothing negative, but the effects really aren't significant. So you will see some endocrinologists go with it and say, let's try it, and some, who poo-paw it, but whatever. Just wanted to let you know about liothyronine, just give you a little bit of information about that. And that liothyronine, again, is T3. That's a hypothyroidism medication. Let's talk about the parathyroid glands. So again, where these are located, of course, on the thyroid gland, right? Whenever the thyroid gland is removed, they try to save the parathyroid glands because these are really important for calcium, right? For calcium purposes. So they'll try to save those, and they'll either keep them in the neck, but I've also heard of them taking them and putting them in a person's arm. But whatever, they're going to try to keep those viable. Anyone that has their thyroid removed, and one of the common reasons for that is thyroid cancer. Someone has thyroid cancer, they will remove the thyroid, but they're going to try as hard as they can to save those parathyroid glands. They're going to need their calcium levels checked and followed until we can see if those parathyroid glands are still working. But that's what these do. These secrete the parathyroid hormone, and that regulates calcium. And it's super important. Obviously, calcium is very important for our body for multiple reasons. Hypoparathyroidism, it's a direct correlation. Hypoparathyroidism causes low calcium, so it's direct. We're going to treat that with calcitriol. Hyperparathyroidism, it's going to cause high calcium levels, and we're going to treat that normally with calcitonin. That's all we really are going to need to know about parathyroid. I don't go into great detail with that. Just when you think parathyroid, think calcium. Think hypoparathyroid, low calcium, hyperparathyroid, high calcium. All right, blood glucose. These are, again, medicines, very common. You'll probably have somebody on insulin almost every day if you work the unit. Two types of diabetes mellitus. Do not confuse this with diabetes insipidus. Remember, diabetes insipidus is low ADH, caused a lot of times because of pituitary tumors or injury for various reasons. I had a patient once that had diabetes insipidus because of radiation to the brain for cancer. Diabetes mellitus, on the other hand, that's blood glucose. It's all about blood glucose. We're not getting enough insulin or at least blood glucose control. So we're having hyperglycemia. Two types. Type 1, there's no production of insulin. None. So if there is no production of insulin, you're going to be dependent, or this patient is going to be dependent upon exogenous insulin, so medication insulin, forever. We're going to have to give them exogenous insulin. And at this point, right now, only way we can do that is injection. It's typically thought of as rapid onset in younger people, but it's not always. I've certainly seen it occur in people who are a little older. I had a patient one time that was in his 30s. He was developmentally delayed, so he lived in a group home I was working at the time, and he actually developed type 1 diabetes, and it was later in life. Type 2. This just means there's either not enough insulin made, or we're just having a decreased response to the insulin. The body is not utilizing the insulin appropriately, or sometimes it's just it's a weight thing that we've got. If we lose some of that weight, the body will be able to utilize the insulin well enough to control the glucose. There's various other reasons as well. It's not always that. It's typically slower onset, and we think of it primarily in older people. However, again, there are definitely kids out there that are getting type 2 diabetes, so we need to watch for that. So let's talk about those symptoms of the abnormal glucose levels. These are extremely important to understand just throughout your entire nursing career. We'll go with hypoglycemia first, because this can be devastating. This can be more immediately devastating. Lightheadedness is a common symptom. You'll see a tremor or fine tremor a lot of times in these guys. They're usually diaphoretic. They have that cold, clammy skin. And then they'll, depending on how bad that hypoglycemia is, they can have some confusion, decreased level of consciousness, or just be right in a coma, depending on what's going on with the hypoglycemia. Hypoglycemia, like I said, can be immediately life-threatening, depending on the level of hypoglycemia. Hyperglycemia is also life-threatening, but it's usually not as immediately life-threatening. You usually have, we got a little bit of time. However, over time, hyperglycemia can be extremely damaging, especially when it's not extremely high. You have a few symptoms, but nothing that you're really paying attention to, but you're still doing a lot of damage over time. Really high hyperglycemia can certainly be life-threatening. However, like I said, with the hypoglycemia, if you're way too low, it can kill you a little quicker than hyperglycemia would. We got a little bit of time with the hyperglycemia. So let's talk about those symptoms. Thirst. They're constantly drinking, right? They're constantly needing water a lot of times. Polyuria, so they're urinating a lot. They have a rapid, thready pulse and fruity breath. These are a lot of times associated. So polydipsia, polyuria, polyphagia, they're also eating a lot. Because their body is starving. Even though they're eating all this, and even though their blood glucose is really high, the glucose isn't getting to where it needs to be, right? So the body's not able to use it. So they're still trying. They're like, I'm starving, even though obviously they're not. They just keep trying to eat to help with that. Medicines that we use for this, one of the primary is insulin. There's different types of insulin. You have rapid acting, short acting, long acting, and intermediate. Let's talk about rapid acting first. That's Lispro, also known as Humalog, Aspart, also known as Novolog. There's others as well, but those are the two most common ones you're going to see. Usually onset's about 5 minutes, 5 to 15 minutes. Can peak in about 30 minutes to 2 hours and last about 1 to 5 hours. So it's short acting. It doesn't last very long. It gets onset, though, real quick. Short acting insulin is our regular insulin. Onset's about 30 to 60 minutes. Peaks in about 2 to 4 hours, lasts about 6 to 8 hours. Now, you'll find different times for these depending on the resource. You'll find some resources that'll say that short acting can onset in 15 minutes or whatever. Don't worry so much about that. I'm just going off of what your book's telling you, but just have a basic idea of when these do. And if you stick with the ones I give you here, we're good. But so if you see a little variation in resources, it's fine. I'm definitely not getting that nuanced with the exams. I don't expect you to get that nuanced, but I do expect you to have a general idea. So rapid acting, I know it's going to act pretty quickly. It's going to peak probably within 30 to minutes to an hour. I know it tells you within 2 hours. Fine, that's fine too. But I know it's going to be it's not going to last very long. Short acting, same thing. I know it's going to get in there pretty quick, start acting pretty quickly, but not last super long. With these two meds, you've probably learned somewhere, I know when I was in nursing school, all they talked about was the only medicine or only insulin you can give IV is short-acting insulin. It's your regular insulin. The only insulin you can give IV. And then I got out in the real world, and the first time I had to give IV insulin, they're like, here's some Humalog. And I'm like, no, I can't do that. Can't give that IV. Like, no, you can't. I'm like, no, I can't. I'm sorry, I think it was Novolog. I apologize. I think it was Novolog that I had the first time. And they're like, I called the pharmacist, and the pharmacist was like, no, you totally can. He sent me the information. I looked at the insert. The thing with rapid acting insulins is just always check to make sure, because a lot of times they can actually be given IV. But you want to check, make sure it's safe. So if you have questions, just call the pharmacy. Say, hey, I just want to make sure, it says the doc ordered 10 units IV insulin and you sent Novolog. I know you sent it. I just want verification from you that this is okay to give IV. And they'll be like, sure. Hopefully, if not, they'll maybe correct themselves, but you are going to be a good nurse and check on that. But just know that there are times, in fact, I don't think I've ever given regular IV. Most places I work, it's the IV compatible rapid acting, which is fine. Just always make sure that you know that it's okay, that the type you're given is okay. Regular, though, we do know that is okay to give IV. These long-acting insulins, these are not okay for IV. We have the intermediate, which is your NPH, and then your long-acting. So let's talk about intermediate first. NPH is the cloudy one. It's onset about 1 to 2 hours, can peak in about 4 to 14 hours, and last about 10 to 24 hours. Most commonly, I see it around 16 hours. At least most resources I see tell you about 16 hours. But that's your NPH. It's intermediate, and sometimes it's mixed with regular, as you probably remember from lab, having to mix the insulins. You don't see it as often because a lot of times they'll just nowadays come in a pre-mixed vial, but it does occur. I've had to mix insulins, I think, twice in my entire 12-year career in the field. Now, in lab, I've done it 7,000 times, but in the field, I think I've done it twice. But I have done it, so it is good to know. When you're mixing them, you want to obviously inject into the cloudy first, the air, inject air into clear, draw cloudy. Just make sure you remember that from lab. And then you got your long-acting. That's your glargine, which is also known as Lantus, and your detamir, which is also known as Levemir. These onset about an hour. There's no real peak with these. These are just supposed to, they're called basal insulins. They're supposed to keep your blood sugar or help regulate blood sugar throughout the day. They last about 24 hours a lot of times. So action of insulin, just replace your endogenous insulin. Replace the insulin that your body normally makes. And your insulin, of course, is going to stimulate glucose to get into the cells so your cells can utilize that glucose, right? So just because you have hyperglycemia Doesn't mean your body can still be starving because there's no energy there to help. The cells aren't able to utilize that because that glucose has to be able to get into the cells, and the insulin's the one that helps carry that in. Indication, of course, type 1 diabetes, definitely. Anybody with type 1 diabetes has to be on exogenous insulin. But we also sometimes use it for type 2 diabetes depending on the severity of the diabetes. Adverse effect, the obvious one is hypoglycemia. So we're going to definitely educate people on the signs and symptoms of hypoglycemia because it can be a life-threatening situation. Contraindications, hypoglycemia. So certainly don't want to give these meds until we know what their blood glucose is. We would not want to give them these meds if they are currently hypoglycemic because it's going to obviously cause further hypoglycemia. Be careful in people with hepatic impairment or renal impairment. Also be careful in people that are NPO. Now that's a tricky situation. Here's the thing that you need to remember. The most important part about this. If you have a patient that's going to be NPO, let's say they're going for surgery. All right. Patients are going to go for surgery and they're diabetic. They have insulins ordered. What you need to understand is I need to do something with those insulins. But am I the one that makes that determination? No. We're the nurse. We can institute nursing interventions, but we can't do medical interventions without an order. So you need, when the surgeon calls and says, hey, I've got them scheduled for tomorrow at 6 a.m., they need to be NPO at midnight. Your next question needs to be, okay, they're on insulin. What do you want to do with it? The surgeon usually is going to pass that off on somebody else, but at least you know who they're passing it off on. Sometimes a surgeon may just tell you, they may take ownership of it. It's not common. A lot of times they're going to tell you to get endocrinology or family medicine or somebody involved, whoever, the internist, whoever happens to be there. So it could be a resident, it could be whatever. And then you'll contact that person, whoever that is. And you'll say, okay, the patient's been scheduled for surgery at 6 a.m. They're on these insulins. What do you want me to do with them? The common response is hold the rapid and short-acting insulins, check blood glucose every 4 hours. A lot of times if they're on long-acting insulin, like those type 1 diabetics, they will go ahead and give them like half, or they may tell them to go ahead and take the whole dose, whatever, because the doc knows, right? The doc's the one that understands what's going on with this patient and what's best for them. So you're going to do whatever that doc orders to be done. You're not going to do what you're not going to do is say, okay, the patient's NPO, they're on insulins. I'm just not going to give them any insulins. That's not a good idea. I have seen multiple times where that's occurred and it's negatively affected the patient. The one I can think of offhand was during clinical. We came in to take care of a patient. The patient was going to go to surgery. When the blood sugar was checked, blood sugar was like off the charts. I couldn't even check it with the AccuCheck machine that we had. They had to draw the blood and send it down. It was well over 600. So now surgery's off, right? No one's going to do surgery on somebody whose blood glucose is that high. So we spent the whole rest of the day trying to get the blood glucose down and not overshoot it, which you're going to. It's very common then to overshoot it, and now you're trying to correct it. It just turns into a mess. The problem happened when the surgeon called and said, hey, I've got them scheduled. We were able to get them in at this surgery room at this time. Make them NPO. And the nurse said, oh, okay. The nurse got that information at night, didn't want to call the on-call, just decided to just not give the insulin. So she didn't give the the fast-acting insulins, but also didn't give the long-acting nightly insulin, unfortunately. And she's type 1. So she needed that long-term insulin. Yes, she's NPO, but it doesn't matter. Your body still is going to produce or still utilize glucose that's available. If it doesn't have the insulin to help it do that, then your blood sugar is just going to go high. And that's exactly what happened. I've seen it multiple times. It's not the only patient I've seen that on. I've seen it before. So again, if the patient is in PO and they have insulins on board, we have to get a hold of the doc and say, dude, what do you want to do with this? What should I do? If she would have called the doctor and the doctor said, no more monkeys jump, said, hold the insulin, then that would have been on the doc, right? She held the insulin. The nurses held all the insulin and blood sugar spiked. That's not what happened. And that's not what would have happened. The doc this person was a long-term type 1 diabetic. They had to have something. The doc would have been, hey man, let's hold those rapids, check blood glucose a little bit closer. Give me a call if it gets above 200. Otherwise, let's give her half her dose of her glargine or whatever it was that was holding her. I said glargine. Yeah. Whatever was holding her. And then they would have gone on and she would have ended up having surgery. Instead, she had to stay in the hospital a whole other day, lose an entire day without that needed surgery. And then, of course, that day feel awful because she's so hyperglycemic. And then we chase that. We bring it down. So now she feels awful from that. And we overshoot her because that's going to happen. So just bad outcomes. So that is a caution in PO. But make sure you know, man, I better call somebody and figure out what they want to do with this. Interactions. Beta blockers. We talked about this already with the last with lecture a few lectures ago. Beta blockers can block the symptoms, the normal symptoms that people feel of hyper and hypoglycemia. Any other drug that affects blood glucose levels can interact, and alcohol can also interact with insulins. So what's our patient teaching? Well, the obvious patient teaching is how to take it, right? We want to make sure they understand how do you take this medicine, how's it delivered. Make sure that they can do it, right? That they can draw the medicine up appropriately, that they can inject the medicine appropriately. We're going to teach them about the signs and symptoms of hypoglycemia and what to do about it, and the signs and symptoms of hyperglycemia and what to do about it. We'll teach them about how often to check their blood glucose. A lot of times when you're on insulin, you're checking your blood glucose with every meal and at night. We do have devices now, insulin pumps and readers that can give you a constant, they constantly are watching your blood sugar. So you can just look at your device that you got and it will tell you what your blood glucose is. And then you can actually program that pump to give you the medicine, to give you the insulin. So, okay, blood glucose is 230. I know I need about 2 units with that according to what my doctor told me. So I'm going to give myself 2 units. Those are pretty cool. We're going to teach them about a healthy diet, right? Try to teach them it's not like you can't have sugar. You just got to have everything in moderation. So you go to a birthday party, you can have a small piece of that cake. Just know what it's going to do to your body. Make sure you're checking your blood glucose a little carefully, or a little more carefully, and that you're ready to respond. So it doesn't mean you have to completely avoid everything, but you probably shouldn't eat the whole cake, although it looks good and tastes amazing. And I know I personally would probably go ahead and eat the whole thing with the ice cream. But if I'm diabetic, I'm going to know I better not do that. Just have a sliver, enjoy that, and make sure I watch my blood sugars a little closer. They'll need to know to keep their follow-up visits. They're going to need to have follow-up labs. Yes, they're checking their blood sugar consistently, hopefully, with their AccuCheck machine, but the doc's also going to want to do a blood draw on that. Check it that way, check A1Cs, things like that as well. Sulfonylureas. These are a PO medication. that can be taken for blood to help hyperglycemia, basically diabetes. But these are going to only help type 2 diabetes. These are not for type 1, because how these work by stimulating insulin release, right? It stimulates those beta cells in the pancreas to release the insulin. So you've got to be able to produce insulin for these to work. And we know type 1 diabetics can't produce insulin, so therefore they do not work for type 1 diabetes, only type 2 diabetes. That's your indication. Adverse effects, well, can cause some hypoglycemia, so we'll need to know those signs and symptoms. It's contraindicated. We already talked about that. Type 1 diabetes. You can't take these with type 1 diabetes. Also, wouldn't want to take these if you're allergic to sulfa medications. Sulfa medications, thiazide medications, sulfonylurea, all those. Right, this is sulfonylurea, but sulfa drugs. We'll talk about sulfa drugs when we get to antibiotics. But if they have sulfa allergies, they shouldn't take these. Be careful if they already have some renal or hepatic impairment. We're just going to kind of watch that a little closer. Interactions, beta blockers. We already talked about why. Because beta blockers can block the signs and symptoms of hyper and hypoglycemia. So we're going to just have to watch that blood sugar a little closer. Also, alcohol can affect them as well. Our patient teaching, very similar to insulin's as far as checking your blood sugar, knowing the signs and symptoms of hypo and hyperglycemia, how to treat the hypoglycemia, dietary changes. As far as treating hypoglycemia, we'll talk about, actually, we'll talk about that when we get to the last slide here. We'll do that later. All right, metformin. Metformin is another medication that can help people control their blood glucose. And again, it is only taken by those with type 1 diabetes. It helps increase insulin sensitivity and decreases hepatic glucose production. And again, it's pretty much only type 2 diabetes. I don't think I've ever seen it in type 1. Another set of people you may see this given to is somebody with polycystic ovary disease. This can sometimes help with that. We're not covering that right now. But I wanted to throw that out there in case you ever do see that in somebody, a female, and they're like, they're not diabetic. Why is the patient getting metformin? You kind of have an idea. Oh, maybe they've got PCOS, because that's sometimes used for that. Adverse effects. GI distress is the most common, right? People get a little nausea with these. They can also affect vitamin B12 and folic acid levels. They can cause a deficiency in those. And they can cause some lactic acidosis potentially as well. Contraindicated is injection of contrast dye. So if the patient's going to go down for a CT with contrast, they will want to hold their metformin. The goal would be to hold it 48 hours prior to and then after. It's not always that easy, though. There's going to be times when they get into, they have an emergency situation and they need an emergency CT. Obviously, they didn't know to hold their metformin the last 2 days. What we're going to do then is check their creatinine. We're going to check their creatinine whether that was held or not, but we're definitely going to check the creatinine for these emergencies. As long as the creatinine, usually the doc's cool with it as long as it's less than 2. But there's always special circumstances, but at the end of the day, usually less than 2. Follow your doctor's orders. They're going to go ahead and do the CT with contrast, but they're going to tell them to hold their metformin for at least 48 hours and then contact their doctor before restarting the metformin. They may, depending on what's going on, the doc may say, no, you know what, your creatinine looked good beforehand, you feel fine, you say you're doing good, everything looks good, let's go ahead and start you back up. But they also, very common for them to say, yeah, let's go ahead and check that creatinine one more time before we restart it to see where you're at and see if there was any damage done, because we don't want to cause any further damage, because these can potentially affect the renal system. So that's your primary contraindication, contrast dye. If they're acidotic, though, we can cause lactic acidosis. The last thing we want to do is continue to cause worse acidosis. So acidosis would be contraindicated as well. And then renal disease, because we can cause some renal problems with these. Be careful in people with alcohol abuse, heart failure, and interacts with alcohol. And we talked about contrast dye. It can interact with contrast dye, cause further damage to the kidneys. So again, let me just reiterate with the contrast dye. Best case scenario, they would stop it usually about 48 hours prior to the CT, and then stop it for at least 48 hours after the CT. What we're going to teach patients is definitely hold it and don't start it again until your doc says it's cool to start. So just contact your doctor whenever he tells you to contact you, usually 48 hours, and see what they want you to do. They may want to get another renal, creatinine test, or they may tell you it's okay. But whatever it is, we know that they need to hold it until they contact their doctor and doctor tells them it's okay. There will be emergency situations where they have taken metformin and, well, the bottom line is you got to have the CT. The creatinine looks okay, so we're going to go ahead and use contrast. That does occur, but best case scenario, so anytime you're answering an NCLEX question, if it doesn't say emergency situation, it's a best case scenario. We want them to stop it for 48 hours prior to, 48 hours after, and contact the doctor before restarting. Patient teaching. Well, we're going to teach them about checking blood glucose, how to do that. Teach them about GI distress. A lot of times that GI distress will improve. Some people report an increase in flatulence with these medications, and that can be embarrassing, certainly, totally understandable. And if you get that call or you get that patient that complains about that, reassure them that a lot of times that does get better. It does improve. Our body gets better at responding to that, and doesn't that normally does improve. But I can certainly understand how that would be embarrassing to somebody, and it would cause a potential issue with compliance. This is normally taken with meals. It's a lot of times twice a day, so it's breakfast and dinner. But sometimes, it depends on the patient. Maybe it's once a day, maybe it's more, whatever. Normally taken with meals. And we're going to teach them about the dietary changes. All right, so glucagon. Now let's talk about what do we do to help decrease the blood glucose, or I'm sorry, I apologize, increase blood glucose. How do we treat hypoglycemia? People will respond differently. Everyone responds their own way to low glucose. There are common signs and symptoms, surely, but we typically think of less than 70 as being hypoglycemic. Some places may say less than 60. And the people will respond differently on different levels. Some people at 50 already start getting shakes, diaphoresis. They're just not acting right. Some people, though, at 30, 25, they look like they're doing okay. 25, they may start having some general symptoms, but I've definitely seen people in their 30s and they're acting fine. I'm like, oh my God. They're not going to be acting fine for long, though. So don't always take exactly what they're looking like and acting like as what's going on with their blood glucose. Certainly, we want to make sure that the clinical picture matches the lab. But if the lab tells you 30, and they're looking great, I would probably get another machine and check it maybe real quick if that's available. If not, I'm going to just go ahead and give them the treatment, whatever the normal treatment is, and probably send a lab or send a sample to the lab. But I'm going to go ahead and treat them because I've definitely seen people whose blood glucose was low and they're acting perfectly fine. But however, if I didn't treat them, they were not going to be acting fine for long, and then they were going to be in extreme danger. Can't have that. So it's definitely possible that the machine's wrong. If I have the chance, if there's another machine available fairly, within a good amount of time, I will go ahead and grab that, check it again, and see where we're at, and then I'm going to treat it. Before I treat it, I'll go ahead and get the blood sample if that's what's needed, if that's what your protocol tells you to do, and send it, which a lot of times they do. But I'm not gonna just not treat it. I'm not gonna just wait for that blood result to come back, because it could take a while. It could take an hour. Even if you send it stat, it could take an hour or more depending on what's going on with that lab. And your patient may not have that. So I'm going to go ahead and just treat it with whatever the protocol says. Your protocol is that's your directions. Those are your orders. So you have to follow the protocol. You always have to follow the protocol. The reason why I make such a big deal about that is because the protocols are different. They're generally the same. A lot of times it starts off, is your patient conscious? Are they able to follow commands? If yes, give them 3 ounces of juice, or however many milliliters of juice. Maybe they'll say 60 milliliters of juice. Whatever it is. Whatever they tell you to do. And then check again in 15 minutes or however long it tells you. And then if it continues to be below 100 or 110 or whatever your protocol will tell you, because again, they're usually a little bit different, but the same general thing, either give them more, if it still continues to be below whatever level that is that they tell you, or whatnot. And then they'll tell you to follow it up with a protein snack and a complex carbohydrate. So that a lot of times that means cheese and crackers or cheese and peanut butter. The protein snack is important because, again, protein will offer energy to the body, but it does so slower, right? So it will help maintain that blood sugar. Whereas if we just gave them juice and that was it, their blood sugar will go up, but then it's possible it crashes right back down in a short period of time, because those carbohydrates, very easy to use. Your body uses them up and just gets rid of them. So we usually follow up with a protein snack. If they're not able to follow commands and they're not or not conscious, you would then go to a parenteral, whether it's sub-Q or IV, and that's your glucagon or your D50 usually. However, I have seen protocols that went straight to glucagon or D50 for whatever reason. Usually the D50 that they go to, or the dextrose, whether it's dextrose 10, dextrose 50. I have seen protocols that have that. I think it was IU who had that for a long time, and then we had a huge when that hurricane, earthquake, whatever it was that went through Haiti. Evidently that was a place where we got a lot of our dextrose. There was a huge shortage of dextrose there for a while. So then they changed their protocol, and they may have kept it there. I don't know. But the bottom line is you got to check your protocol, whatever it tells you to do. They're usually the same, though. Can they talk? Can they follow directions, and they're safe to give them something to swallow? Then here, give them some juice. But always check it. Make sure you know what the protocol is and you follow that. And they may have different amounts of juice. Usually it's like 3 ounces, but heck, they could tell you more, they could tell you less. I don't know. Just the bottom line is you're going to follow whatever the protocol tells you to do. If they're not able to follow commands, you will go a lot of times to either D50 or glucagon. Glucagon works a little bit differently. Your D50 or your dextrose, whether it's D10, D50, it's just sugar, right? It's sugar water. It goes in your vein and immediately works, right? Your body can immediately use that sugar. Glucagon works a little bit differently. Glucagon actually works in the liver. and it helps the liver release glucose. Well, releases glycogen anyways, and the glycogen turns into glucose, but whatever. Or I'm sorry, I guess it breaks down the glycogen and releases that as glucose, but I'm not getting into that, the physiology so much as just understanding that glucagon releases those glycogen stores you have. So therefore, you have to have glycogen stores in order for this medicine to work. Most of us have that, but we only have so much. So you can only use glucagon maybe twice, right? At the same time on the same patient. If you have to use more than that, you got to go to D50 because it ain't going to work because your liver's going to be out of glycogen. So that's how glucagon works. It accelerates the breakdown of glycogen in the liver, and that's going to release glucose out into the bloodstream. Our indication, hypoglycemia, is the primary indication. There is another indication that you'll sometimes see with this medicine. Somebody gets a food bolus, or a food bolus stuck in the esophagus. So basically, the most common culprit is steak, right? They're chewing on some steak. They swallow too big of a piece, and it gets stuck in their throat. That's the most common culprit. There are others because there's people with different esophagus problems, but most commonly it's steak. And it gets stuck in the throat. They'll give you glucagon sometimes to help release that because the glucagon will help relax the esophagus. And it also actually, when you give it IV quickly, can cause vomiting. So it'll relax the esophagus and you'll puke it out. I've definitely seen that. But anyways, that is another indication that you will sometimes see this given for. But the most common indication, the most common one is hypoglycemia. It's commonly given sub-Q, but you can give it IV. I've only ever given it IV for food stuck in the throat or a food impaction in the esophagus. I've never given it IV for hypoglycemia. I've always given it sub-Q, but whatever, you can give it either way, depending on whatever the doctor orders or whatever your protocol tells you to do. So adverse effects, we already talked about. Adverse effects. We already talked about vomiting, nausea, vomiting, especially with that IV. But it can also cause tachycardia and hyperglycemia, of course, because that's your primary. Anytime you're taking something for one thing, it can obviously cause the exact opposite. So we're taking this for hypoglycemia. It can cause hyperglycemia. Be careful in people that are pregnant or lactating. And it can interact with warfarin or oral anticoagulants. It can increase the risk of bleeding when on those. So just be careful with those. Patient teaching. They're going to need to know the signs and symptoms of hypoglycemia. They're going to need the importance of maintaining proper intake. So obviously know the signs and symptoms of hypoglycemia. How to check your blood sugar. Check it appropriately. Make sure that they're checking it correctly. And honestly, the longer that somebody's been diabetic, the less likely they are to be compliant with checking their blood sugars. It's just the way it is. And then the importance of maintaining adequate intake, that they're actually, if they're going to take their insulin, they need to know they need to eat. We still need to eat appropriately. And then we'll teach them about their diabetic treatment regimen. I have seen this medicine also, people have this in the home for emergency situations, at which point we will also need to teach family or whoever happens to live with the patient how to give it. Because it can be a life-saving medicine. If the person finds them down at home, they need to call, obviously, 911, but we can give them this medicine and bring that up. If you find somebody that has gotten, their blood glucose has gotten so bad, they're not able to eat the candy or drink the juice that they normally do at home, the loved one can give them this and actually save a trip to the emergency department, because once they get them back to where they're able to talk and follow commands. Now they can start slamming the juice or whatever the doc tells them to do, right? Or eating the cheese and crackers, whatever, to keep it up. So I've certainly seen this as something people can take home. They can administer it themselves for sure, but a lot of times it's an emergency thing that a family or a loved one will give. So we'll need to teach them on how to give it. So again, when treating hypoglycemia, we want to check the protocol. Most important thing for in the hospital protocol. Follow that exactly as written. Most commonly, it's going to be, can they talk? Or I'm sorry, are they alert to baseline and able to follow commands? Is it safe? Basically, what they're asking there is it safe to give them PO medicine? Can they do it without choking? If they're confused, I'm probably concerned. I don't want to give them some juice and have them aspirate the juice. It's so much easier for me just to give them some glucagon or D50. Way easier and much safer than to have them choke on some juice, because now we're into potential aspiration problems and pneumonias and all kinds of mean, nasty, ugly things. So let's not do that. So if there's a question as to whether they're going to be safe to eat or drink, don't give them anything. Go straight to the next part of the protocol. If your protocol just tells you go straight to D50, then by God, just go straight to D50. Be careful with D50. It is a vesicant, can be. Needs to be given in a big vein, given slowly, but believe me, you don't have any choice but to give it slowly. The first time you push D50, you'll know that. You'll remember this conversation and go, oh, no, he was right. I can't give this fast, because it's sugar. It's go home and mix, a quarter cup of sugar, quarter cup of water, mix it together, and there's your D50. Now, don't give that to somebody IV. It's not sterile. But there it is, right? And see how thick that is. It's pretty darn thick, especially when you're trying to shove it through a 20-gauge IV. I mean, if you really want to take it to the next level, hook up a 20-gauge IV and then shove it through there. And then you'll see how hard that stuff is to give. You don't have any choice but to push it slow, because it's just tough to give. It can hurt your hands. I've definitely seen some people that, had some, they would end up just giving it to somebody else to give, because it can hurt to give. All right, that should be enough on this one.